Hello, I'm Elise Brogan. I'm a GP in Derbyshire. I'm doing one of the fellowships, the GP Task Force fellowships at the moment. And as part of that, Gail Walton has very kindly agreed to have a chat with me. We've been doing these kind of weekly, haven't we, for the last few weeks, just going over some of the updates to try and make it a bit easier for everyone. So would you mind introducing yourself, Gail?
Hi, I'm Gail Walton. I'm a GP in Ilkeston in Erewash. Been there a long time. I'm also an LMC and GP Task Force exec, and it's really useful doing these because there's such a lot of information comes out each week that I feel I'll incur Alish's wrath if I don't mug up in the days before we're due to meet. So it's a really useful opportunity for me, and thank you.
I think that's both of us. It does make us read all the attachments, doesn't it? So the first thing we were just going to mention briefly, weren't we, was a few things that have come out. The first being dental practices. They're now triaging their own patients. So if we get a call with someone with a dental problem, we're just supposed to tell them to call their dental practice. Is that right, Gail?
Yeah, absolutely. We're not dentally qualified. We don't have any specialist dental knowledge. So as in all times during our GP work, there will be odd instances where we feel we really need to, for example, prescribe antibiotics, but that should be few and far between, and the dentists really are the experts, and that's where we need to direct people.
Perfect. And they're triaging them and sending them for emergency dental care if needed. The other point was only really relevant for North Derbyshire, but that Chesterfield isn't doing paediatric surgery now. So if any of the Northern Derbyshire practices need to refer, there is a number to call so they can speak to a surgical registrar and organise the child going to Sheffield for surgery. That's all correct, isn't it, Gail?
It is. I suppose on that point, I would just add that you'll have seen over the course of the last week or so the increasing concern that children and all ages really aren't attending in the same volume as they were regarding physical and mental health problems to us as GPs, nor to A&E, and there have been those highlighted warnings really and advice for people if they are feeling ill, if they think they need to seek medical attention, then there are safe environments for that to happen, be it video consultations, telephone triage in the first instance, and face-to-face appointments. So whilst in some senses we're enjoying some quiet periods in general practice, we also need those contingencies to be able to see people and keep our patients well.
Yeah, absolutely. The other thing that we were talking about, and you were saying neither of us have been able to find much guidance on, was regarding chaperoning and whether that's needed during telephone triage.
Yeah, when you mentioned this, I thought that's a really interesting point for us to consider, isn't it? Because we are so aware in our face-to-face consultations about offering chaperones. We've all got our notices up and we've thought it through for our practice settings, not least because of CQC requirements. So we're quite clear about that and face-to-face consultations. What I hadn't thought about so much until you mentioned it was video and to a lesser extent telephone consultations. I haven't been able to find any particular national or local guidance, so I think what I came down to was some quite common sense values of, if we are video consulting, to keep it looking and sounding professional. So excuse me, what are we wearing? What's the background that we set against in terms of a room and a wall? And if we're at home, you know, what's our background there? The language we use can sometimes be different if we're on a phone or on a video. So think about all those things. You told me, Elise, when we were talking about this earlier, that you'd had some examples and people had used chaperones to come and sit in with them, and I think that's a really good idea if we're going to be doing.
That's all right. You can just go straight through.
if people are doing, in effect, a more intimate examination, a chest wall, for example. So yeah, thinking about that. Also, you were saying that the patients, the examples you've given, had people with them, and I think that's really good as well. Telephone consultations are often recorded by practices, so you've got that safeguarding in place sometimes if somebody comes back with a complaint. And I think good documentation is always key, isn't it? So yeah, in our practice we're using an auto consult so that we're noting that we're doing telephone consultations in the COVID pandemic. So again, good note keeping. You can go back and see why you did something in the context you've done it in.
Yeah, and I think that's, yeah, it's all that kind of common sense, logical advice, isn't it? Because you say there wasn't any guidance, but it was something that was brought up on a Zoom chat with some doctors this week. One thing that was brought out in the emails was about COVID advanced care plan. Would you mind saying something about that?
Yeah, there's been quite a lot of talk, hasn't there, about, and I'm just looking at my notes. So there was the standard operating procedure brought out by the NHS, and as one part of that it talked about advanced care plans and gave a good template actually for people to fill in themselves. As a practice, we've had conversations about how we can get advanced care plans done in those, for those patients that haven't got an existing care plan. And we've vacillated a little between the thought of almost cold calling people, those that we don't know terribly well. Pre-COVID, we'd had quite a big push on trying to get care plans done for our elderly and frail, but there are still a good number that haven't got a care plan in place. I think there are a lot of different reasons for that. I think cold calling is difficult and uncomfortable and probably not appropriate. And with a pandemic, we've got to consider the rapidity of somebody's deterioration. So have we got time to do a care plan? Has the patient got capacity and understanding? Are we going to be able to actually do that plan in the ways we've got available to us at the moment? So by telephone or video link, is that actually available to us? So I think it's very much a case by case basis. I think a longer term approach is we should all really consider ourselves as a patient. How do we feel about developing our own care plan? I've got a number of examples that I think have been really useful for my thinking. So I've got a patient who is in her mid-50s. She's had a brain tumour for some time. She rang me last week to say, look, I just want to reiterate, I have got an advanced care plan. I've used the one on the Macmillan website. I know you've got a copy of it, and I just want to make you aware that that's what I've done and they're my wishes. Another personal example, I had an aunt who died recently who'd left a lot of information. So patients, if we've got that relationship with patients to have the conversation, that's really, really useful. I think also respecting that for some people, my mum who died 10 years ago would not have wanted to discuss anything to do with advanced care planning. It just wasn't on her radar, and she, I think, chose to have an element of denial. So I think we're very good as GPs in picking up those verbal and non-verbal cues and helping patients along with that. So just to highlight, I think the template is pretty good, and I think it's something we can use going forwards with patients after the pandemic as well. I think what's really important is the stuff that's come out as well, saying you can't have a one size fits all. You can't blast around a letter and a generalised care plan simply based on somebody's frailty or age or comorbidities. There's been, actually very topically in the newspaper this morning, there was an article where a GP practice had to send out a full-scale apology because it had sort of tried that approach with patients. So it can't be applied to a group of patients. Care plans are individual, they're bespoke.
Yeah, okay. Oh, thank you for that. That's really useful. The other thing which relates to that about end of life was two different things came out, didn't they, this week? One was the fast track document and one was regarding dementia complex palliative care. What did you take from the emails and the updates this week?
Yeah, I think there's a huge amount of work being done across the whole end of life palliative care, increasing community care needs going on at the moment. Dr Pauline Love, who's a GP in Bakewell, who's the CCG lead for end of life care and is a LMC member, has done vast amounts of work, and big parts of the palliative care team have worked on this. So like you say, the two separate but very much related things come through this week. So one is the end of life fast track document. So this is additional care and support in the community. It's a short document, it's short form, it's available on the LMC website, and practices will probably have got it by other means as well, and it allows anybody in the community team, so the GPs or the district nurses, to recognise increasing needs and to get that help come through from the continuing healthcare team. We talked a bit last week about acronyms. This one comes under MLCSU,
Right.
CHC, and that is the Midlands and Lancashire Clinical Support Unit Continuing Healthcare Team. But it's a very simple form, simple email, telephone contact details. So that's a care package to help people stay in the community. The other new service, which comes on board on Monday, so this Monday the 17th of April, and is available 9 to 5, Monday to Friday, is, like you say, the Dementia Complex Palliative Care resource. I can send you the information about that, but it is on the website. And this is the palliative care team supporting people with advanced dementia and palliative care needs who are living in care homes or in supported living. So the team will supply support to the care homes team, advice to the people looking after them. They will provide a bespoke service of medication review and advice and help. So quite an extensive package available there. That's by telephone referral, and like I say, details are on the LMC website, but I could also send you the one-page quick guide if people would find that helpful, just to keep on the desktop.
Thank you. I think we got that in the last LMC email.
Yeah.
Attached. Yeah. No, that is. It's so useful to know that all these things exist.
Yeah, absolutely. And everything's changing at pace.
Yeah.
With better during the pandemic.
Yeah, it's keeping on top of it and knowing that it's all there, isn't it? I've made a little folder on my emails, COVID-19, and so I'm just putting all the emails with the attachments in there, and hopefully then it's something, I'll remember that I need to look for something in it. That's where it'll all be. So So the final thing that we were just going to mention was about wellbeing. So I know that you've been involved in a lot of the creation of the wellbeing support networks that are around at the moment.
Yeah, I think it's so important for us as healthcare workers and also for our patients to know what's around and what's available for us, that we're not working in a vacuum and that there is help available. I put a lot of information together at the sort of outbreak of the pandemic, and that was in a bit of a piecemeal fashion. It's still available on the LMC website. Since then, we've added to it, and there's a sort of pyramid of care also now added on there that people can have a look at. So there's those lower baseline levels of keeping ourselves well and healthy, with our simple day-to-day routines. Susie Bailey talked this morning on Radio Derby about general well-being, and very much mirrored this idea of keeping a structure to your day, keeping well, but also then higher up the pyramid there are other things available. So we talked, I think, a while ago about the Well online resource that we can all tap into, Thrive, a mental health wellbeing app, a lot of stuff out there for patients, although the IAP services, so Talking Mental Health Derbyshire, Insight and such like, aren't currently seeing patients face to face. Derbyshire Healthcare Foundation Trust has got a telephone service that people can ring for mental health support, and there are details of that both on their website, so DCHFT, and on the LMC website. So there's a lot of stuff around and available, and it comes back to this thing about keeping ourselves well and patients knowing that we are still there to talk to them.
Yeah, because we can't look after the patients if we're not feeling okay.
No.
Well, not very well.
And GPS, I suppose, as well. I think we mentioned GPS, and now GPS have also opened their rapid access service that's available to all of us as GPs, shorter telephone mentoring sessions that could be really helpful.
Yeah, I bet that'd be really helpful. That's great. Well, thank you very much, Gail. I think that's everything that I wanted to go through. Does that sound okay to you?
Yeah, I don't think there's anything else. I know last week we mentioned that we might have an update about the coroner and death certification and verification. It's still work in progress, both nationally and locally. So watch the website space for any changes to that.
Great. So maybe, depending on when any updates come out, we could maybe go over that next week.
Yeah, I think so, and maybe talk a little bit about what I think is starting to be labelled the recovery phase, in as much as looking at what work we haven't been doing in general practice that we will be starting to pick up, and how we might do that so we don't come back to a huge post-pandemic backlog.
Yeah, that any way to avoid that does sound very helpful.
Yeah.
Okay, that's brilliant. Yeah. Well, thank you very much again, Gail.
You're very welcome. Take care. Have a good weekend.
You too. Bye.
Bye.